one of those opportunities where the least amount of effort can result in the maximal amount of results. So let's go to the next slide. So these are some tips that I wanted to suggest, and I think these are things that are often missed in effective verbal de-escalation. So the number one bullet is respecting personal space. So obviously, if you're talking to a psychotic patient, they think the mafia is trying to get him, and they're also somebody that is going to be the likely patient that's going to take a swing at you. It makes a lot of sense to be at more than an arm's length or leg's length away from the patient. That way, for your own safety, but also they don't feel threatened like you're up in their face. I've seen people try to, people who are really into focus, making facial contact or getting up into somebody's face. That's the last thing that you want to do. I realize if your conflict meter is triggering, you may do some of those things and not realize, but it's very important to kind of check yourself there, especially if you're going to be in a close quarters of an ambulance when this happens. You really need to be back in a place where you can take a step back if there's something that happens. But it is a really important cue to give this person a little bit of a bubble so that you can have this communication. So along with that, so many times I've seen it where hospital security comes in, or even a provider or a nurse or CNA or whatever, who's having a bad day. They start to clap back at the patient. Really, we got to make sure that we check our internal, how we're feeling internally, and avoid triggering people and escalating. You know, if you watch, any kind of, I don't know, some of these videos that go around online where, people are getting into arguments with, agitated people, a lot of times we're fueling the fire here. We're bringing the spark to the gasoline. This person's already ready to spin off, and we have to be very careful about how we do that. So really, it takes an opportunity to check yourself, realize, like, how am I responding emotionally to this? How is my tone of voice going to be, interpreted, and reeling that in. If you can't do it effectively because of what's happened with a patient, if you're that spun up, get your partner to help you if they can keep a level head, and realize, when you've had enough, you're going to have to kind of separate yourself. So the other thing I see that's done wrong a lot is when you establish the verbal contact, the person is already in a state of disorientation. We'll have more than one person talk to them. So you'll be saying something, and then your partner's like, yeah, this, it really isn't good for patients who are delirious or who are psychotic. They can't kind of they already have all this sensory input coming into their mind. They can't have more than one person talking to them at once, even though the other person may be trying to be helpful. Agree among yourself and your team, like, one person is going to be the point person that's going to engage the person. And so make sure to introduce yourself and your title and affirm to them that you're there to keep them safe. Make sure that you're concise in your language, be right to the point. Remember, these people they're going to have a limited bandwidth to understand what you're going to tell them. And so you have to be really simple with your communication. So next slide. So it's important to, when you connect with the patient, that you establish what the patient wants and identify what their feelings are. So in a person who's agitated, you could present with a question. It's like, hey, you seem angry. What can I do to help you? And, they're going to come back with some kind of response. Most of what they're going to tell you is something you can't do for them or that you can't comply with. But it is important to identify their emotion. That can be a very important step to disarming someone who's upset. You can agree with the patient or agree to disagree. A lot of times they're going to say, I want you to let me go. I want to get out of here. And you would basically at that point say, I understand that you may feel that way. We are going to make sure that you're safe, and I don't think that we can let you go with what's going on right now. Set clear limits as you establish a rapport with the patient. You say, hey, you can't be swinging your arms at me. That's not a safe thing to do. That's going to hurt you or hurt me. And do that in a calm and but controlled voice. Um, and then the other step that I find a lot of success with is I may not be able to release you, but I would like to make sure that you're comfortable. Can I offer you a blanket, a drink of water, something like a creature comfort that can disarm the patient? So you're not giving them exactly what they want, but you're giving them something else. And that can be a very effective tool. Often after a psych patient gets brought to the ER, that's one of the things that I'll do is offer them, medication, nicotine patch, any of those kind of things. I realize some of those things are not available, but it's kind of a bait and switch type scenario where you're redirecting someone who's agitated or delirious to something that they might actually want, and so it gives them it's a great way to kind of redirect a patient. So next slide. So there's some important skills. So what happens if that doesn't work? It often doesn't, right? But if our effective diplomacy doesn't work, then we have to proceed to the next step. The first thing that should be done before you implement a restraint, whether that be physical or chemical, is offer them medication to treat the underlying condition. So this is a distinctly different scenario where someone is allowing for voluntary treatment. So, hey, you seem really upset and anxious. This can be very a stressful scenario. Would you like me to give you a medication that can help you relax so that you can, go to the hospital or, be transported to where you're going? And often this is an opportunity where you're getting consent to administer a medication. This is not a chemical restraint. It's a treatment of the underlying condition. Remember that your safety is the most important step here. If you are with the patient or you're not quite back in the ambulance yet, or even in the ambulance, if it gets to the point where things are not going safe, get pulled over to the side of the road, retreat to safety and ask for help. Contact law enforcement. Very important step. We want to prioritize our safety as number one. So next slide. So here's the St. Luke's general policy on restraints in patients. And so I generally, and really, I agree with this statement, but it's something that we want to make this kind of our mantra. Basically, all patients who all patients have the right to be free from restraint imposed as a means of coercion, discipline, convenience, or retaliation by staff, or based on patient's restraint behavior history. St. Luke's Emergency Medical Services strive to be restraint free. Restraints are never to be used as a form of discipline or coercion or for convenience of staff or request of law enforcement. So I think we would agree. We don't want to restrain somebody as punishment. We only want to do this when it's absolutely necessary. We want to strive to not use it unless we absolutely have to. And we definitely only do it if it's medically indicated. We don't do it for convenience, and we don't do it for law enforcement either if they request it. It's really a patient-centric uh, type of intervention. So next slide, please. All right, so physical restraint, the definitions are important. Any manual method, physical or mechanical device, material, or equipment that immobilizes, reduces the ability of the patient to move his arms, legs, body, or head freely, and or a measure to prevent the patient from exiting the bed chair, such as mitts, tied down, soft leather, or ankle straps. Next slide. So obtain and consider pertinent information. So we're going to go ahead and decide, all right, it's time to physically restrain the patient. They're at risk to themselves or others. All the other methods, offering them medications, verbal de-escalation has failed. Remember, once again, a cue, make sure there's nothing medical going on. Consider in addition to the behavioral disorder, we want to make sure the medical stuff is covered. Make sure to obtain the adequate history from family members, bystanders, law enforcement. Make note of patient surroundings for potential drug use, etc. The method of restraint shall allow for adequate monitoring of the patient and shall not restrict the patient's ability to maintain an airway or compromise their neurologic or vascular status. So basically, we're going to make sure that the patient is safe when we apply these, make sure that we understand all the medical stuff that's going on. So go to the next slide. Alrighty, so physical restraints. So prior to application, and I'm sorry, this is going to be really dense, and I would encourage you to. I'm going to go over this, but please read this document. This is from that the attachment that we sent out. So prior to application, ensure equipment and personnel are ready, including adequate resources based on the assessment of the situation. So in the next slide, we're going to talk a little more about this part, but basically, if we're going to have to restrain a patient, it's ideal to have a number of people present. We're going to have to make sure that we have adequate hands to engage the patient. If we don't, then we shouldn't be engaging with the patient at this point. If it's not safe, if it's just you in the back of the ambulance or you and your partner, you don't think that it's going to be safe based on your assessment, wait until additional help has arrived before you do that. So secure restraints to different points of the frame stretcher, taking care of the positioning so that basically it's not attached to any part of the moving stretcher. Um, Make sure that what happens if you're order a fixed wing? We'll get there. Um, so once the restraints are applied, immediately reassess the patient's condition. Make sure neurovascular status of the extremities are intact. Treat the patient for the medical condition at that point and make sure that it's covered. So reassess the patient, and this is going to be something to make sure that you guys review, but this is what needs to be every 15 minutes, we need to be doing a reassessment on somebody who's in restraints. And so document the readiness to continue or discontinue, physical and psychological comfort, cognitive status, circulation, vital signs, and continuous monitoring of the airway. Make sure that we're notifying the receiving facility the restraints. Next slide. All right, so special restraints. A lot of times our patients are going to be restrained by police or by some type of jail staff. And so this is an important point that we need to go over here. So if somebody is in handcuffs, that's not considered a physical restraint. We determine that to be a forensic restraint, meaning that that's not something that that we need to document because the police have detained the patient or the jail staff. But we do need to make sure that there's a few rules that are followed when this happens. So that's the difference. Handcuffs would be a forensic restraint, not a physical restraint by us. Law enforcement must accompany the provider in the back of the ambulance if the patient is transported, and the purpose being that they must have the key to remove the restraint, and so they need to go with us. So if we are taking a patient who's incarcerated from point A to point B, that's a necessary step. We see this a lot in the pre-hospital setting when someone's handcuffed for medical clearance, or if we are transporting, they need to be in the back with us. There was a specific called out. So yeah, I'm not saying you don't need to document those. Ian, whoever just made that statement, it's not a physical restraint in the medical sense, is the distinction that I'm trying to make. So yes, you absolutely need to document that, but that is a forensic restraint, as defined by this policy that St. Luke's has written. So, very important step here. Patients are never to be transported with their hands behind their back or in the prone position while in a forensic restraint. So although we're not responsible for the restraint, we have to make sure that that's complied with. So we can't put somebody in the hog tie position like the guy in the picture here. And by policy, they can't be handcuffed behind their back on the stretcher. So that's something that we may not have realized, but that's something that we need to follow. So go ahead, next slide. All righty, so these are some examples that are important that can help us understand what's a physical restraint and what's not. So there's a lot of definitions here. I think when in doubt, document it as a physical restraint, but often there are cases where it's not considered a physical restraint. So, for example, temporary immobilization related to a medical, diagnostic, or invasive procedure. So, for example, commonly excluded methods or devices would be like a splint, arm boards, safety straps, those little boards we use to keep IVs in pediatric patients' arms. That does seem kind of silly, but That's not a physical restraint in this sense. The forensic restraints we just covered, handcuffs, although I would generally document that they are present, they are not a physical restraint that's implemented by us. Voluntary mechanical or postural support devices. So this would be like short spine boards, some KEDs, something that would keep a patient up posturally because they've had a stroke. Something, it would restrict their movement in some sense, but it's part of their medical treatment. Our stretchers are not considered, or spine boards, for example, are not considered a restraint. So basically, if a patient is like intubated, sedated, obtunded, and we're holding their arms to keep them from pulling out their ET tube, that is not necessarily considered a physical restraint in this sense, in this document here. So a brief physical hold, if you're going to start an IV and the patient says like, hey, I need to hold the arm in position to start an IV briefly, it's something the patient is consenting to. This is not considered a restraint. So holding their arm down to establish an IV, or if they ask for help, grabbing your other hand or something like that, as long as it's a consent that you've had the consent of the patient, this is not a restraint. And so anything like a physically or a age appropriate intervention, like a car seat or a high chair, is not going to be a restraint for a kid. Lastly, safety straps on transportation device. So that would be like our seat belts on our stretchers. Those are not considered a physical restraint. So person who is, anyway, we'll get to that. There's going to be a question on that later. So if that makes sense, something that you would wear conventionally for any patient for a safety purpose that's not just, for restraining or holding a patient is not considered a physical restraint. So go ahead to the next slide. Alrighty, so when applying the physical restraints, we talked about this earlier. Number one thing is get help. Make sure that you're not overmatched, and be surprised that those old ladies come ready to punch. They can be the worst ones. So the ideal scenario is to have someone for each extremity. So one person for the right leg, one person for the left leg, one person for the right arm, person for the left arm. If you don't have the equipment or the people available, try to maintain the situation as best you can until you get those people. So the optimal thing to do if a patient's laying on a stretcher or a bed is when the person who's going to take control of the leg, it actually works a little better if you go just above the knee. Put your full body weight on an extended arm and hold the leg down. So if the person's laying down, that kind of immobilizes the leg and you kind of control the femur. The problem with grabbing the ankle is the person can kind of yank it back really hard. They still have a lot of strength there. It's a little more effective to grab it above the knee. In the upper extremity, you can control based on the wrist or the crook of the arm. Those are effective ways to restrain the arm. The only problem with grabbing the crook of the arm is that they still have their hand free. They can squeeze you, grab you. So make sure that if one person per extremity, it's a little easier to control. Make sure to try to do that. So really, we're never going to want to put anything on the patient's head, face, or neck, with exception. So really, kneeling on the neck, or, we all know that's probably not a good idea based on what we've seen, but it needs to be called out specifically. Now, there are some things that we can do. A non-rebreather mask, if a person's going to spit at you, we don't have a spit hood. A non-rebreather mask with the oxygen turned on is an acceptable intervention. As far as the neck goes, we want to maintain range of motion. We don't want to put any pressure on the neck. But if the person's, a C-collar actually can be an acceptable intervention here that can reduce range of motion and reduce their ability to bite you. So if that can be safely applied, that is one exception where we can put something on the neck. So make sure, again, we're not going to ever place the patient in a prone position. If police are involved, we're going to advocate for the patient and ask that they get removed or placed on their back or in some type of recovery position. And we're not going to transport that patient until we can do it safely. So don't sandwich a patient between spinal boards. That's kind of more of a Texas thing that we had to call out back in the day. Hog tying a patient, that's where they're supine and their knees or their upper extremities are bound to their lower extremities. Remember that we need to monitor the patient while they're in these restraints as best as we can. If the optimal is to use pulse oximetry and tidal CO2, blood pressure monitoring, and cardiac monitoring if able. So next slide. So remember, we the reason why we don't allow patients to be prone or in restraints is that they can't breathe. It can lead to hypoxia, and it's been implicated in custody deaths more with police departments. Even healthy patients, they're going to start to develop their forced vital capacity goes down by about 40%. Their end tidal CO2 increases by 15%. Their cardiac output even decreases. So it's really not a safe scenario. We already have people who potentially have a medical problem. Obviously, these are not the right way. This isn't the right way to place a patient. So next slide. So when I look at a patient, especially if I saw this lady in the photo here, basically, I'm that person's an airway risk, all like 100%. Like if we're holding them down, or they already have a likelihood of obstructing their airway. Be observant of physical features that could predispose a patient to become hypoxic if they're restrained. Morbid obesity, cardiopulmonary disease can drastically decrease the patient's ability to adapt to external stressors. So we're going to have to evaluate our patients for those risks when we engage in these scenarios. So next slide. All right, so chemical restraints. So basically, the difference between voluntary medication and involuntary medication. It's going to be a drug or medication used to restrict the patient's behavior. It's going to restrict their freedom. It's not a standard treatment for their underlying condition. So drugs and medications, that we have in our protocol, we'll discuss. So again, we're going to reaffirm that we've attempted our verbal de-escalation. We've offered voluntary medications. If they're going to continue to pose a risk to themselves and EMS, then this is when we need to intervene. We have to be very good at documenting that. Make sure the appropriate medication based on clinical presentation, which we'll discuss more. And so once we've administered those meds, we need to obtain and record vital signs, which is Q15, continuous cardiac and pulse oximetry, and ensure patent airway. And then we'll need to report the medication, the time, all those kind of standard things. So next slide. So chemical restraints, we're going to talk about our medications very briefly. We could almost do an entire lecture on this, and we're already getting long enough. And this is a little exhaustive, I understand, because it's a policy that St. Luke's has, but it's important that we understand. So if we want to break this out later, I'm just going to kind of hit some high points. So medications we're going to have that kind of meet this criteria are our benzodiazepine class, whichever one we have at the time, whether it be Versed, diazepam, or lorazepam. It seems to vary based on drug availability. Ketamine and droperidol are going to be our medications. So with droperidol, we really need to be mindful of that QTC like we discussed earlier. And we can also, I'll talk a little more about how Benadryl can be helpful to be co-administered with droperidol. If you're in doubt, give one of us a call. We can help walk you through. Often other medications have been tried by the time that this would happen, and so we'd be happy to help you. And I think that was very effective in this case this time because we were able to start some medications before the patient left. So let's go to the next slide. Alrighty, so which medication should you use? So our benzodiazepine class, it's going to be more effective with the primary agitator being anxiety. So if the patient's just extremely nervous or anxious, they have a phobia of going into the medical system, and they're combative for those reasons, this can be a more effective medication. It also can be very helpful in patients who have a sympathomimetic drug on board, like cocaine, methamphetamines. This is a really great medication to calm them down. It may not be completely effective, and there may need to be other medications, but it's kind of our lowest hanging fruit. It's easy to do. This is one of the medications I would offer right up front. Hey, let's give you a benzodiazepine medication, calm you down. A lot of people will go for that, and you can kind of prevent things from escalating. We need to be a little cautious in elderly patients. It increases their fall risk. If we're going to have them, in the ambulance, this should be something we can control, so we don't need to be completely afraid of it. but it can really mess with patients who are already delirious. May not be the best medication. Also, be careful with co-administration with opiates. As you know, it can cause a decreased respiratory drive. So droperidol, we kind of chose to start bringing droperidol on board a few years ago because it has dual benefits. One of the problems was we were getting rid of phenergan, promethazine, because of the risk to necrosis to veins. We chose this because it kind of has a dual function. It's actually an antipsychotic medication, also works really good for nausea. And so this is actually a little underutilized. We're becoming more familiar with it here in Twin Falls of how to use it effectively. But this is actually a really great medication to use in an agitated patient because it has some effects. And this is allowed based on our acute behavioral disturbance protocol. So, as discussed, it's an antipsychotic medication. It's really going to be most effective for patients who are delirious or who are psychotic. Because that's its function. So these older patients, the UTI lady that's really delirious, it can be very effective. We have to be a little cautious with it. So in this scenario, we're allowed to do 2.5 to 5 milligrams, which is a high dose. Normal dose for nausea is 0.625. So with these higher doses, we need to be very cautious about looking for prolongation of the QT interval. So over 500, we're going to be a little more, we're not going to want to re-administer that medication, and we may want to avoid it. The other thing we need to watch for is extrapyramidal symptoms. So an extrapyramidal symptom is, it's a dopamine, it alters the dopamine system, and it can cause dystonic reactions like jaw clenching, abnormal movements. And it also, most commonly, it will lead to akathisia, which is basically the person gets an extreme creepy crawly feeling. They can't hold still. They just want to get out of there. So it can have a paradoxical effect in those patients. The way that we would typically manage that in the hospital is we would give Benadryl to the patient. So appropriate, 25 to 50 milligrams of Benadryl co-administered with that can kind of counteract those extrapyramidal symptoms, especially the akathisia. So, if you are going to give those high doses, I would generally consider you follow it up with some Benadryl to kind of help manage that. And of course, Benadryl has some sedative effects as well. So you're going to kind of really be right where you want to be. So those are the reasons why we'd use one or the other in those scenarios. So let's go to the next slide. Alrighty, so if we have the patient that's like, whoa, this guy is like extremely sedated or extremely agitated, like I really need to get this guy down. He's going to really hurt himself or someone else. So this is when we get real aggressive. So I'm generally would advocate for there. You kind of have two ways to go here. The droperidol that we talked about, you can actually in our policy you can co-administer with a benzodiazepine. So you basically give them all of them. Droperidol, benzo, Benadryl combo. In the hospital, we call this the B52. So Benadryl, 50. It's 5 of Haldol, 50 of Benadryl, 2 of Versed. In a sense, droperidol is your Haldol in this scenario. It's just a medication that we have. It has that same effect, same class. So basically, you're going to give all 3 of those medications together to really put the patient down. Obviously, we need to be very cautious about monitoring. These medications can be given IM. So that would be one scenario. If, as far as guidance goes, I would say somebody who is more of the psychotic type patient, that they have a mental illness or delirium, I would kind of favor the droperidol benzo Benadryl combo. If somebody's like high on drugs and they're like, the cops are trying to hold him down and they're like, you need to get this guy down really fast, that's kind of where I would do more of the ketamine. But there's a little bit of a judgment call that you can make, and that's just my personal take on it. But these are extreme scenarios, right, where we really need to put someone down. So our ketamine dose, our IM dose, so these are going to be people that we probably don't have a line on. We're going to have to, slug them with some IM ketamine. So the 4 milligrams per kilogram, max 250. But we're going to have to be very careful with how we take care of this patient. There obviously is really times where EMS has dropped the ball in the past across the United States. One such case was the Elijah McClain case, where they probably gave the guy too high of a dose based on his body weight. They overestimated that. They thought he was bigger than he was, probably because he was extremely agitated. And then they released him back to law enforcement, and he died in police custody. So, if we're going to do this, we have to be really careful about our monitoring. But this is what we're going to do. Is one of these scenarios. All right, next slide. So this is like the last scenario. This should definitely not be something that we do frequently, but there is a justification and there is an opportunity. So if we have a patient that we have tried sedating them, we've tried kind of everything else available, and the only way we're going to get this patient from point A to point B, their life depends on its situation. These are going to be the ones that are going to need intubation and paralytics. We need to make sure that we do this. It needs to be justified medically. And, we would treat the patient the same as we would anyone else. We're going to assume it's a medical condition. We don't just give a paralytic to the patient. We're going to give, adequate sedation so that they can be safely transported. This would be a specific consideration for our flight team. If you're in the back of the helicopter and there's just no other way to get the patient to the point A to point B, and it's a mission sensitive issue, then this would be a justification to do that. It is the most extreme form of managing the situation, but it should be based on sound clinical judgment, and we really need to make sure we have adequate documentation to support our decision to do that. Okay. All right, next slide. All right, so this last step here, documentation. So we need, this is in the policy, but basically we're going to document the circumstances leading up to it, suspected causes of delirious behavior or agitation, the behaviors the patient exhibited, the scratching, kicking, biting, those things like that, the reason why we chose to act. We are going to document that the least restrictive measures were attempted before we administered the next step. We're going to monitor continuous monitoring and assessment, the positioning of the patient, any injury to EMS or personnel, and law enforcement forensic strength use. So that, as discussed before, we are going to document the forensic restraint, but it's not considered our physical restraint, if that makes sense. Okay, so next slide. Alrighty, so I have a couple questions for you just to kind of make sure we understand the policy, and this is kind of an open forum to answer. Let's go ahead to the questions that were asked during the presentation. Are we able to pull those up? All right, and I do realize this is like a lot of information, so please take your time to review the policies, because this is what's going to come up when, if there is an issue, we're going to have to make sure we follow these policies.
Dr. Burtis, we only had one question online. Ian was asking your thoughts or concerns on the amount of fluid given IM when you have to jump to those different cocktails like 5 mLs. If you're trying to get all the ketamine, or you're starting to do that where you really want to inject one time, you don't want to have multiple injections on an agitated patient. So what are your thoughts on that?
Yeah, so I'll definitely have to get back to you on some of this. So one of the downsides is going to be our ketamine concentration. If we have the high concentrated form of it, it's less of a concern. But there is, I know at least the B52, I'd have to confirm with the droperidol and get back with a pharmacist, but the B52, the ideal thing there, so that would be the Haldol, Benadryl, Ativan, which we can't do. They actually co-administer those, so they draw them all up together. So they were safe to give together. That's the nice thing about it. I'll have to see if droperidol can be co-administered like that, and so that would minimize the total volume. But again, we're going to get into a problem, based on what's available to us. Yeah, sometimes it can be a lot of volume. It's not ideal. So we'll have to kind of work through that. But, then in principle, administering these medications to keep the patient safe is what's justified. If we have to give a really high volume injection, that's, although not ideal, we may have to look at that. But that will be an interesting follow up to see if we can co-administer, drop a syringe of our 5 and 2. I missed the, did he have the concentration for the ketamine?
Ian says our high concentration ketamine would be 5 mils at our max dose.
Okay. Yeah, so that one's definitely not the problem. It's going to be some of the other formulations that we've carried in the past, and that changes based on availability. So yeah, I think we'll just have to take the loss on the volume administered in order to get the patient where they need to go. And then earlier we talked about.
Go ahead.
No, sorry.
Oh, I had another question in the room, so go ahead and finish your thought.
Okay, yeah, go ahead. Next question.
Okay, Andy has one.
Hey, good morning, Dr. Larson. I know that the droperidol dosing, when we've been giving it for nausea in the field, seems like the ideas are quickly dismissed once we discuss the dosing of the 0.625 because it's kind of hard to draw up, number one. And number two, I know that 0.625 was sort of a dose that's given primarily in the OR prophylactically to prevent nausea. But for my knowledge, and back when I did this OG 30 years ago in the field, we would give it at a higher dose, like 1.5 to 2, I believe, with good results for acute nausea. And by all means, anybody in here poke holes in that. If anyone's as old as I am or older, please weigh in, or if you have droperidol experience for nausea in the ER, I'd love to hear if other people have used higher doses or just an explanation for why that dose is so small.
Yeah, so for nausea, you're right. If I remember correctly, we had the 0.625 dose, but I believe we have an opportunity to repeat that a short time later. And we do allow for higher doses, in the behavioral disturbance category. So, and if you look at the acute behavioral disturbance, we allow for 2.5 to 5 milligrams for droperidol. So, much higher dosing allowable, but we're in an extreme scenario. So, since we're sort of on the discussing nausea management and stuff, we can probably table that for a later thing. But for the time being, 0.625, but you can repeat is kind of the way we would do that. But you're right. I often will give 1.25 or 1.5, I believe, in the ER.
It's just super fun to draw that up.
Fun to draw it up.
Oh, Leslie, did you have a question too? Okay, one sec. Let me bring the mic.
I have a question with the Doc Burtis with the ketamine for acute behavioral disturbance. We don't have an IV dose for it, and maybe I'm reading it wrong. It just says
That's
acute
right.
And
No,
is there, yeah,
you're absolutely right. Yeah, we need to fix that. That's one of the things I was going to bring to the protocol committee. So we do have some patients who are do have an IV, and that was something I have in my notes to go over. So look forward to an update from the protocol committee. But you're as the time being, you are correct. IM is only listed there, and so that's something on our fix it list after I've reviewed this protocol to present it. So thank you for the call out.
Yeah, good catch. Hold tight.
so at this time, no IV ketamine for behavioral disturbance because I know our pain and
I mean-
inoxalis is 0.3 to 0.5 IV. So I don't know if we can bridge that over, or if we should just wait for the protocol to be updated.
Well, I mean, let's see. Let's pull up the ketamine sheet. If you want to kind of permit something to talk about verbally here, or let's see. So yeah, I mean, 1 milligram per kilogram is generally what I would do to start. So that's our induction is 2 mgs per kg. So I don't want to quite put them out enough where I'm going to intubate them. The 4 milligram per kilogram dose is generally, since it's IM, it just takes a little more time. Honestly, I think you could almost do the RSI induction type scenario, 1 to 2 milligrams per kilogram IV. Um, I often can do, like really painful procedures on a patient with 0.5 per kilo. So I'd say 1 milligram per kilogram is going to be your sweet spot in acute agitated patient. Um, Maybe try 1 milligram per kilogram in the redose, but we'll put a formal allowance for that in the protocol in the future.
Well, it says pain and anxiolysis, intubated, non-intubated, and you have 2 different doses. So if they're intubated, 1 mg per kg, 5 minutes PRN, and then not intubated, 0.3 to 0.5. So it's pain and anxiety. So if your patient's acutely agitated and you have an IV, give them the anxiety dose per whatever situation you find yourself in. That's how I've had it worded at other agencies, for, sedation or continuing sedation. IV ketamine is, 1 milligram or 0.5 to 1 milligrams. Everybody does their own thing, but it's not listed just because it's not listed for, specifically acute behavioral disturbance doesn't mean you can't just use the anxiety dose of ketamine for that.
Yeah, I would agree with what you're saying for sure. In this scenario, though, we'd almost want to go a higher dose because we're talking about somebody who's like extremely agitated, delirious. If you can get away with the lower dose, by all means, we use the least invasive means necessary. That's what that's the kind of the essence of what this is about. But I think we probably should have a heavy dose available. Let me talk with the other docs and make sure that we're in agreement before we make an official statement. But you're absolutely right. This is an anxious patient. You could say that. You can use that justification, but we actually need to fix the IM or the behavioral disturbance aspect of this protocol. So anyway, yeah, good discussion. Then thank you for talking about it.
Yeah, it's got 4 mg per kg, so. Well, right, but yes, but if they're extremely agitated, I don't know, the times when I've used that as opposed to the 0.3, 0.5, is you can't get an IV in them. There's 6 people holding them down. If you got an IV, I think the 0.3 like Adam was saying.
Yeah,
And
yeah. I
just
mean, it's
the discussion
Go ahead.
got brought up. We had a patient the other night that we flew who wasn't just like a disturbance behavioral thing, but she was extremely difficult to manage and had already had some Versed and had a limited effect. We had an IV. It was just keeping her on the gurney and keeping her compliant and keeping her following commands. And so the point is when we looked at this, we didn't actually have an IV dose. And we were like, well, gosh, because of what he's talking about here, Doc, is that this is a litigious scenario and we want to make sure we're crossing our T's on our I's. We didn't want to like break protocol and say, well, this is kind of what we think we should do if it went south or changed. And we didn't want to give our patient an IM shot with an IV in place. Well, you could, and you could document it, but it just brought up this discussion. That was all.
Yeah. So we definitely are going to work on that. But for now, there's ways we can do it.
Thank you, Doc.
We may just need a little bit of a higher dose. So yeah, I think it is good discussion, and this is kind of the point of going over this because it's a hard thing to do. It's like generally you should never do this, but when you have to, make sure you cross your T's and dot your I's. So this is how it goes. So all right, was there any other questions for? And I'm sorry if I knew this was going to take longer than I thought it would, but let me go through these questions really quick. Unless there was any other stuff from the group.
Just for the record, the mafia scares me too.
Oh, I know. Well, hey, there's been patients that literally did have the mafia or FBI after them. That's actually been documented. So sometimes that's actually true. So anyway, alrighty. So in this case that we talked about, was the seat belts that the patient had on, was that a physical restraint?
Answer's no in the room.
That's correct. Yeah. So it's part of our normal safety straps, things like that. Although the patient might have felt like they were restraining him, that's a safety, so that's not considered a restraint. So we have a patient that is exhibiting signs of delirium tremens and a benzodiazepine is administered. Is this a chemical restraint? So this is the patient's not consenting to give you the medication, but he is experiencing a medical condition that you're treating.
The answer in the room is no.
Yes, that is correct. No is correct. Because you're treating an underlying a medical condition, right? So a patient is given the appropriate. Sorry, I keep hearing my echo and I think that I'm getting a question. All right, so a patient is given an appropriate dose of droperidol and lorazepam after exhibiting aggressive behavior towards EMS. After a thorough evaluation for underlying medical concerns and attempted verbal de-escalation has failed, what form of monitoring and frequency must be implemented?
They said Q15, vital signs, end tidal CO2, all of it.
And specifically, the other thing we want to make sure of is cardiac monitoring. Keep an eye on that QTC. So, all right, next slide. Oh, was that it? Oh, there was another slide of questions. Hold on.
Oh, here you go.
Okay. Oh, thanks so much. This is just one I wanted to make sure we clarified too. So, and then Alan can start. I'm sorry for how long it's taken. All right. So, a police officer or jail staff has a patient in forensic restraints, handcuffs, and shackles. What must happen for St. Luke's policy to per St. Luke's policy to safely transport the patient?
They said not prone, and the officer has to
Mhm.
come with the key.
Right. And so positioning for the handcuffs remind us that we can't have them behind the back. Um, and then this is another important question. If we have given a chemical restraint to a patient, can they then be released to law enforcement afterwards?
No.
Okay, very good. Really, that's kind of the essence of that Elijah McClain scenario is if we're giving medications to the patient, they're now a medical person, they're going to the hospital, they're not going to be released into police custody. And if that becomes an issue, we really need to escalate to AOC, MAOC situation because, that person's extremely at risk if we've had to do that. Alrighty, and then lastly, I'll just answer this one so we can move on. But basically, the most effective medication to reduce agitation in an elderly patient with delirium or psychosis would be your antipsychotic, your droperidol, for example. All right. Okay. Well, thank you for everyone's patience and questions. Please familiarize yourself with the policy. It's something that we, really want to make sure we document well, and it can really save us a lot on on the back end. So let's make sure we do it right, but also, use the tool effectively when it's needed.
Great. Thank you, Dr. Burtis. All right. Next, we'll do our chart review with Dr. Bean.
All right. First off, I want to be cognizant of time. That was a great presentation from Dr. Burtis. I think that's an important thing to review. But I just want to see what else we have so we make sure we end on time. So give me how much time you want me to use and I will try to abbreviate it. Oh, we'll be fine then. Okay. All right. So let's go ahead. I got 3 cases, but one of them is really just most of this is just going to be education. So I think most of us have heard about this one, but this was one that came out of Twin Falls. So this is a 37-year-old that had a circumcision done that afternoon in Twin, had some bleeding with it after the circumcision. So cautery was done. They watched the kid. It looked fine. And so the kid went home. Mom went back to Wells, Nevada, and then noticed that the child had gone from like crying and eating to like not very active. So she noted that his diaper and onesie was wet. And when she looked to see what it was blood. So her brother was a volunteer firefighter. So she ran over to her brother's house. They decided, let's run this kid back to Twin, but he seemed to be bleeding more. So they called for EMS, and then EMS ask Air St. Luke's to respond. So we arrived on scene. We attempted 2 IVs unsuccessfully, so an IO was placed. The child was, I said actively nothing. It said actively bleeding. So 2 grams of TXA was placed on the skin. At first I was like, 2 grams? I'm like, it wasn't IV. It was topically. So appropriate to be placed over the area of bleeding to try to get this taken care of. And then the kid looked terrible. His heart rate was in the 200s. His blood pressure was kind of up and down. So they elected to give their blood products, which is whole blood at 10 mLs per kilogram times 2. The vitals, as I just mentioned, were super unstable. Sometimes he was had maps that were quite low, down into the 30s. That all resolved after the blood was administered. So we got to the ED, and then a cautery and direct pressure without success occurred once again. So urology was called, and they came and put a few stitches into the area that was bleeding. And he was observed overnight and then continued to follow up with urology. The thing that really brought this case forward was the thought that for whatever reason, we'd misunderstood that we thought the child had not received vitamin K prophylactically, but actually the child had. He was a large for gestational age baby that had hypoglycemia, so spent some time in the NICU, and actually had all these shots and immunizations. And I want to make sure that we separate that out. Shots and immunizations, they're not the same. So the child did well, but it brought up a couple of things for education. And I'm going to say good job to the crew on that one, because we don't get too many 37-year-old or 37-day-olds that we have to use IOs and give whole blood to. So it was good thinking on our crew's part. Next slide. So the thing that was interesting, though, is in spite of the fact the kid was unstable, the hospital really wanted to review the blood products and whether we should be given whole blood. And when we wrote this policy, we included neonates, peds, and adults with the whole blood policy. There has been some literature in the past that would say that neonates are at risk of whole blood products, especially to alloimmunization and to allergic reactions. But this was a male, so it didn't make a lot of sense. When I looked at the literature really has never shown that this is a true risk. However, St. Luke's policy still has this as we don't give whole blood to neonates, and that's for blood transfusion, that's defined as less than 4 months of age. But that puts us in a little precarious situation of like, well, so what do we do if we have somebody that's in extremis, is in hemorrhagic shock like this child? And the answer is, well, we need to come up with, we need to get that policy rewritten, and probably need to look at different options, because frankly, we don't carry packed cells, we carry whole blood. And that's really what the patient needs if they're in hemorrhagic shock. Otherwise, they're going to need the other components depending on how much blood we have to give. So our neonatologists and PICU docs agreed that this was appropriate. So stay tuned. I know that this will be a policy that's going to need to be updated because of what we're going to talk about next. Yeah, question. No, that was done by protocol because it's part of our protocol, but apparently our protocol does not match St. Luke's policy, and that's why it was written up and we were asked to review it. I don't think we've gotten any more updates on that, but that is something that we all have to do. It's one of those things that hopefully we don't have this happen again before we review it, but the policy still stands that we have to save the life and worry about some of these consequences later, similarly when we give it to a pregnant mother that's hemorrhaging. So the answer to this is, yeah, we're kind of in a sticky situation, but you have the support of your medical advisors and your, as well as us as your medical directors. But make sure it's needed. Okay, vitamin K. So this has actually been a very fascinating development in the, at least in the US. I'm not sure what the worldwide stats are. So what happens is when something terrible happens to you or your parents, you generally remember it. And then when those terrible things stop happening, you start questioning whether or not you should do things. It's really fascinating. It doesn't matter whether it's medical, it doesn't matter whether there's just a lot of things that we're like so sure of, and then now our kids are questioning, right? So whether it's, it's like everybody, for instance, 2 generations ago, no one really questioned smoking, right? Now nobody smokes, but now we vape, and now we figure, and it's like, it's all these changes that happen generation after generation, and pretty soon we stop, we forget the reasons that we made those decisions. Vitamin K seems to be up there with everything else, right? It's like when you had, we'll go over this in a second down on this slide, but when you had nobody having hemorrhages as an infant, people just thought, oh, that never happened, right? So now there's this growing literature growing movement out there that says this is unnatural and we shouldn't give kids vitamin K. And in fact, it's just like immunizations, and so it shouldn't be given. Where in fact, vitamin K is not an immunization, it's a vitamin that's injected due to the child's inability to synthesize vitamin K in the gut for the first few months of life. And so it's given to prevent unnecessary neonatal hemorrhage, which was a pretty, we don't know all of the causes of death, but children died frequently 100 years ago, and there was multiple reasons, and this was one of them. Some people also just think it's not natural. Some think that it's contaminated, because there was one study that showed that there was some sort of contamination. There's no mercury in this. There's no other contaminants. There's no heavy metals that are mixed in with this. And some just believe it's not necessary. It's just people who lived before, so they'll live in this day and age. Yes, Jeff. So the issue with the oral vitamin K is it's not effective, and you need multiple doses of it. And so getting that to be compliant is a problem. So yeah, the people worry that it hurts their kid, but it's interesting because that's what we were wondering. It's like you were worried about that hurting your kid, but you circumcised him. But it's kind of the same thing. Just give them a sweetie, and generally that takes away and that's just some of the education. But this is what's happening. And just to get an idea of what that rate is. So 3.4% of births in the hospital are refusing it, but up to 31% are happening in birthing centers. This is important for us because if we end up picking up a child that's under 6 months of age and we ask, we need to ask, tell us about birth and, especially, and, where were they born, at home, a birthing center, in the hospital. And then the next question, if they're at a birthing center, would be, what did they receive for treatment post-birth? Did they get their IV? Did they get their vitamin K? What did they get? And if they say no, it was all refused, then your sensors need to go up that this could be a hemorrhage. Historically, it was 0 to 0.1% refusal up to all the way from about the time we started doing it 60 years ago up to about 2018. And then there was an increase, a small increase, and over the last 3 years, boom, 3 to 5 years, it's gone up to these numbers, and they continue to actually increase year after year. So what does this do to our practice? Why do we care? Because we don't make these decisions, the parents do, right? Next slide. What it does is it changes history taking, right? So when you have a child that's altered or that has bleeding that you can't really explain, you need that as part of your history, because that's going to change the way that you think about this child and think about what you might do for interventions. So what happens, we talked about this, they basically have a natural coagulopathy that resolves when their microbiome in their gut improves, but it takes time to mature. So we've had at least 3 devastating cases of intracranial hemorrhage resulting in death this summer in the last few months. We just don't have those things happen. And it was unclear to all the providers what was going on, because nobody put up at their top of their list, oh, this kid's spontaneously bleeding into their brain, because we just haven't seen this because the incidence of vitamin K administration had been so high. But as these were discovered, we started to realize, hey, we need to start adding this to our differential into our history. And so basically what that means is now all invasive procedures have a increased risk. I mean, peripheral IVs still have to be done and that can be easily controlled. But if the kid needs an LP because they have a fever, if the kid needs a central line because we can't get a line, if the kid needs a any sort of procedure, it's like now we have to start weighing risks to benefits for these kids. And we also have to start thinking differently than, man, is this kid dehydrated? Does this have an underlying heart condition? What's causing this alteration in consciousness? Next slide. Here's the thing that's really kind of, this is kind of like took my breath away when I saw this, that a neonate's 80 times more likely to have a severe bleed, and 1 in 5 will die of a serious bleeding event if they don't receive vitamin K at birth. Which is, that's, to me, I mean, of course, everyone gets to make their own decision, but this is stark. We're going to see more kids dying in our care, and we're going to have more kids in our care as this percentage goes up. Now, is it common? Do 3.4% of kids die? No, absolutely not. But if they don't get vitamin K in that first 6 months of life and hemorrhage is the issue, they have a 20% chance of death. And basically, this could be a sibling holding the kid and tripping, and the kid bonks their head. They're dead. So these are minor traumas, and these happen spontaneously. So you have to be thinking about this along with our non-accidental trauma, about kids that are altered and that have these symptoms. Easy bruising, whatever you might see, they've got to be treated. And of course, the medical community is trying to do everything they can to get parents educated that this is just a vitamin. We're just trying to reduce the risk of death in your kid. Any questions on vitamin K and kind of what things we're thinking of? This would probably primarily be for match, but questions? Mm-hmm. Six months and younger. And interestingly, it's not like, oh, at 1 month, it's much higher than 2 months. It just, I mean, eventually the microbiome just starts producing it, but it's just as high in a 5.5-month-old. But generally you're going to start. So we've got it's a pretty big range considering the number of children that are born and that percentage. There's no good data on a percentage of kids that have coagulopathies that don't get their vitamin K shots because it's such a new thing. We don't have that data yet, but we've had 3 deaths that, in my opinion, I would say were completely preventable with one easy intervention. That's just deaths. Correct. Correct. So it's a new thing, and I expect it to get more prevalent before it gets less prevalent in our current environment. Okay, next slide. All right, the next one, we'll move to the other end of the spectrum. A 77-year-old guy. He came into as a fall to Nampa Medical Center, and he was pan scanned and found to have minimal injuries, just a nasal fracture. But during that evaluation, he developed some VFib, and CPR was undertaken after shocks, and he was given epi and amiodarone, and then ROSC was obtained. Those were bolus doses. And then due to another sequence of events, as they were trying to get him stabilized, he went to VFib again. They got return of circulation, and they put him on a Levophed drip, and initial EKG was unremarkable. He had poor perfusion, a weak pulse, and a wide QRS rhythm. By the time the ASL3 arrived, they were like, something's up here. Can we redo the EKG and get him on some other drips? So amiodarone and epidrips were started along with Levophed and were rapidly up titrated. And an EKG was repeated showing a stem in the anterior septal leads on his EKG. So the plan changed. Instead of going to Meridian, or instead of going home with a nasal fracture, the plan was to go to Meridian to the cath lab. Next slide. So the epi was started and was rapidly titrated along with norepi up to almost max doses, but the hypotension seemed to improve. He seemed to be stable enough for transport at that time. He was on 1 mg per hour of amiodarone as well. So en route, I got a call that says, what should we do if the patient gets hypotensive? We're maxed out on our pressors and we got to still get to Meridian. So, because en route, we discussed, potentially doing some boluses of epi rather than going above our max titration, which seemed reasonable. Interestingly, an idea had been put forward to perform CPR because the patient still had a pulse, but it was weak, it was thready, and actually oxygen saturations were low. And it was like, maybe we can increase circulation and oxygenation if we do a little CPR. So that was tried for a minute to see if they could improve the lower oxygen saturations, which of course, could potentially cause higher CO2, which could worsen the acidosis. So we'll talk about that in a little bit. The patient did arrive with normal vitals at the ED, but the cardiology is like, I can't take him like this to the cath lab. So the ED physician and cardiology were at bedside and evaluated the patient. Next slide. Unfortunately, the patient was stuck in traffic, but they called him and discussed the grave prognosis. A pH was noted to be 6.84, and so cardiology requested an AMPA bicarb, which was administered. He again went into VFib, and another milligram of epi was given. The family's like, boy, this looks bad, and we said, yes, it was, and they said, please withdraw care. So the care was withdrawn, and he quickly went asystole and passed. So then, the crew asked, well, what could we do in the future when pressors are maxed and the patient remains hypotensive or with labile pressures? What's our options? Because we didn't have any other bags of pressors on our rig. So what can we do? So next slide. It's a good question. So I think the thing we discussed, and you guys, I'm happy to hear your ideas. I think when we have unsteady patients on large doses of the pressors that we have, we need to ask for other pressors, whether that be neosynephrine, depending on whether we're in septic shock or whether it might have been dopamine to try to help this heart get flogged a little harder, or even dobutamine, whatever. Have that discussion with the sending provider and say, gosh, we're right up against the wall and we don't have anything else we can add. I get we're going from Nampa to Meridian, but this patient's deteriorating quickly. Now, this patient died, but not everybody does, right? You can have cardiogenic shock or some shock states that are pretty intense and you can survive. It's just a lower percentage of them do. So what can we do? And I think that's the big thing is get more tools at the sending facility so that you have them as options. And if you don't use them, I suppose we either toss them or check them back in, whatever the policy is, but better to have the medicines and not need them. Also, assume, even if you don't have a pH, that the patient's acidotic, and consider trying to hyperventilate them, or at least have your respiratory rate higher so that you can try to make up some of that metabolic acidosis with a respiratory alkalosis. That does help patients, although his heart was gone. Imagine this in a septic shock patient, right? The more acidotic you get, the lower your chances of survival are. So consider using your vent when a patient's ventilated to help with your severe acidosis and making vent changes. CPR, though, is never indicated unless a patient's pulseless. There's been no data that shows that doing CPR helps improve hypoperfusion. It basically takes no perfusion and perfuses, and even then it's questionable unless you have pulses that you can feel. But remember, it's been studied in patients like this that are peri-arrest state, and it hasn't been shown to do much. It was a good idea. I get the idea. If we put a little more pump on the outside of the heart, maybe it'll push enough blood forward so we can increase the oxygenation and so that we can keep this patient alive since our pressors aren't working. And then, let's see, we'll get back to that question in a sec. So I think that it was a crazy case with a lot of creativity, a lot of creative thinking, and a lot of reflecting. And I thought it was very very awesome to review this in QA, but I thought this would be a cool one to bring forth because we do find these cases once in a while where we're like, man, we're kind of stuck between a rock and a hard place. We're out of meds, we're out of protocols, and the patient's dying. What do we do? You know, so I thought it was a good one to bring forward for discussion. Anyone have any thoughts or comments on this one? Yeah, what was Sam's? I'll get back to you in just a sec. Well, I didn't see it. It was, yeah.
So Sam, thank you. That's a great question. He said, what are your thoughts on patients with a pH of 7.1 or less and the effectiveness of vasopressors? And in the instance of presumed severe acidosis, should we be considering bicarb and hyperventilation from the start?
So bicarb, we kind of talked about, I think it was just the last clinical meeting, we talked about bicarb. Bicarb does not fix the problem. Fixing the problem fixes the problem. So this guy's heart's pretty much, he probably had a gigantic MI and he just could not sustain life, right? That's the assumption. He probably, you know, so this one's hard because I don't think anything we would have done would have made a difference. Bicarb is kind of given almost always as a last hurrah instead of like, hey, let's give this now, because you're basically, although it really seems like it should work, bicarb has never been shown to just improve pH. You give it and nothing really changes. However, you can compensate surprisingly with a respiratory alkalosis some, but that metabolic acidosis, when it's severe enough, it's going to win and you're going to die from the severe acidosis. So yeah, hyperventilation, I think from the start is not a bad idea. And when I say hyperventilation, I mean, you know, let's get the PCO2 up a little bit. Like we don't want it in the 20s, right? Let's just get it so we're a 30 to 35, somewhere in that range, and consider, you know, like a faster rate to do that. And in healthy patients, that's probably going to be enough. In unhealthy patients that may have underlying COPD, you might have to alter that IDE ratio. And that was the other question, pressors. Yeah. Well, they're effective at squeezing down your vessels, but they're not effective at, you know, they're probably not affecting the pH. The pH is affected by fixing the underlying problem. So he needed to be able to move blood forward so he wasn't in such a severe lactic acidosis. Septic shock patients need to get rid of their underlying disease process, and DKA patients need to have insulin. That's how you solve that underlying problem. We're just trying to support for as long as we can, hoping that we can get to that point. Just to sit. That is true. So that's actually a really good point. And we shouldn't forget that. So ACLS and PALS are different algorithms, right? But in ACLS, the reason that it's that is, and the question was, for those that didn't see it, for peds less than 60, with part rates less than 60, CPR is indicated. And the reason for that is because generally they have a respiratory cause of arrest versus a cardiac cause of arrest, right? So usually the CPR starts moving blood around the reason is because the kids aren't getting enough oxygenation, which is causing the heart to go into distress. But they do better, and they have shown that kids that before they arrest and peri-arrest do benefit from CPR, but that is not the case for adults. And it's even lower for newborns, or even higher for newborns. Yes. With CPR in the back of, aircraft or ambulances, which is not with CPR, in order to facilitate these patients, and if they do re-arrest them,
not necessarily maybe carry it on the aircraft, because I know they take up a lot of space and stuff, but, have it available so that way the ED could use it and then they could place it before we get there. Sort of a prophylactic, ward off evil spirits, because there's no amount of medication you can sling it and it's going to change.
Nope.
Dopamine aren't gonna do anything.
Right. This is a hard one because there's nothing really we could probably do looking back, right, for him. He probably just ruptured he probably infarcted too large of a area of the heart, or even ruptured his chordae tendineae, and he just was not resuscitatable. But we don't know that, right? We can't look forward. We can always look back. But there are some cardiac cases where where the patient may survive. It may just be the heart's so weak, once you unplug that artery, you'll get it back, or you can get an LVAD or and then you can get a heart, a new heart, and he can survive, right? So there are these cases, right? But these are rare. I mean, we shouldn't expect that doing things differently is going to change this particular one, but there are cases that we could make a difference, and those are the ones we're trying to find. Whether that would work or not, I think that's a good care council conversation. There's a lot of questions about how effective Lucases are in, also improving outcomes from CPR. So we'd have to look at that kind of data. You had a question too.
Yeah, it was just a follow up on. Where you stand with lidocaine as a secondary to the amiodarone, and moving forward with some lidocaine there.
So the question is whether to use lidocaine in conjunction with amiodarone. It's an interesting question. I think there's some schools of thought that say that lidocaine should have never been replaced by amiodarone. Amiodarone doesn't have actually the beautiful effects we think it does during cardiac or pericardiac events. I don't know that there's ever been any benefit, though, to using both. Certainly it could have been tried. But again, I don't think it would have changed much in the way on this guy, especially for the hypotension, which was really his issue. It wouldn't have really increased cardiac output in a way that would have been meaningful.
We have a hand up online.
Okay, go ahead. Online. Ryan.
Howdy, yeah. Not ashamed to admit this was me. We were definitely thinking outside the box vastly here. It was either kind of the choices were watch him digress and code, which we won't get him back, or try something. And that's kind of what we decided, was try something. but what we were going for here was essentially his end tidal CO2 was like 14, 15, 16, which is near ineffective CPR anyways, right?
Correct, yes.
So that's kind of where we got the idea of, this is a pure VQ mismatch. His ventilator settings and everything looked great. His end tidal CO2 was toast. He was just not moving blood. So that's why we decided to do the CPR. And in the thought process there also was kind of what Adam had mentioned on the Lucas devices, where you hear stories of in the back of these rigs where they're doing CPR with the Lucas device and the patient will wake up and start fighting you, right? Or something along those lines. So that's kind of what we were going for with this.
No, I agree. I think last hurrahs happen sometimes, and once in a blue moon they work. I've cardiac thumped somebody and they've brought them back too, but I'd say most people that wouldn't happen. Yeah. So, but the data shows, and we wouldn't ever put this in a protocol, that was, although it made a lot of, you think through it, it makes some sense. It just doesn't have the outcome you would think. It's kind of like the bicarb, right? Cardiology says throw bicarb at him, he's gone. We're too late to do much of anything because we can't fix the underlying problem. So, but it's good to get these ideas out and talk about them, not because we would discourage out of the box thinking, but just because what works and what doesn't. And, I think that you're right. Dobutamine or dopamine wouldn't have made much of the way. Yeah, it's like we could squeeze the heart that's dying harder, but it probably wouldn't have made a lot. But on some of these, we could think like, okay, well, let's think everything we might need, and And that conversation, we probably should have encouraged the ED doc to have that conversation, maybe at bedside before we left for Nampa to Meridian with the family.
Yeah, and before we even left, it was good to note in our chart too that we were actually sitting there waiting when we showed up first time at the bedside for him to VTIB arrest again, and the doc was going to call it, but that didn't happen. He just kind of hung around. So that's
Yeah.
when I asked for the amiodarone drip and the epi drip, and I was like, "Well, you were giving these things during the arrests, and they were working, so let's start them continuously for
Which is a
starters,
great idea.
so we don't go there again." And then number two, what's going on with this heart? And that's where we found the STEMI. But yeah,
Yeah.
interesting case. The guy needed an Impella. Bottom
Yeah,
line.
and interesting. I wonder if it would have happened initially at Meridian if he would have gotten it too, right? Sometimes it's you're fortunate where you're at. Yes. Let me give you the Matt. Okay. Let me give you the microphone. Oops, I don't miss a step.
So at a previous company I worked for, we had a policy that people with profound acidosis, anything below 7.1, usually we saw dopamine and norepinephrine weren't as effective, so we would automatically add on vasopressin because they found that that was working best in the extreme acidosis. Do you have any stance on that?
I have no stance. I can't say whether that would work or whether that wouldn't work. I'll have to look into that unless Dr. Burtis has some more information on that. I think that may have been Sam's question then.
Well, we have a couple other questions regarding vasopressin in the past, so we'll have to look into that a little more, Alan, you and I both, but are we
Yeah.
going to use it? Because, I mean, it used to be ACLS, right? We used to have that, as part of the pressors we'd give, but anyway, it's always a good thought. It is we have to acknowledge some controversial topics here, like bicarb to enhance pressor effect. Does that really get you to where you need to go? I mean, it's all good questions, but it's like, are we doing the right thing or not?
Right. These are all great ideas, and I think it will stimulate some good conversation. Adam, you had one other.
As far as the bicarb, like you're determining, is this a severe anion or non-anion gap metabolic acidosis in somebody who, wasn't previously hospitalized. Like, I don't think it's, necessary to try and equivocate those things because you said, this is a forward flow issue. This isn't a profound metabolic acidosis due to, sepsis or whatever. But I was going to ask, is there anything that we should be aware of in terms of destination consideration versus, Meridian versus regional in terms of how is mechanical support always available 24/7 in Meridian in cardiology versus downtown? Like if, maybe, might not have made a difference for this person, but if we think that, they've coded and they've got low output, is there anything that we need to ask, be like, hey, should we skip Meridian today versus on Thursday coverage wise?
That is a good question. There is no difference in abilities for what the cath lab can do in Meridian and in Boise. The EP lab is in Boise, so if we think they're going to need like a pacer or they're going to need something from EP, then that would be appropriate. But if we're trying to stabilize them from a muscle or a plumbing standpoint, then either cath lab is equivalent. Yeah, we're going to run out of time. This was, I just wanted to stimulate some conversation. I think we actually have a good couple of topics to discuss, vasopressin and the Lucas device, so we will do that. So the last thing I wanted to talk about was just a reminder for everybody. Briefly, this was a 5-day-old that was born to a methamphetamine-dependent mother, and she was preeclamptic for obvious reasons, because she had no good care, the child was born prematurely. He had cardiac arrest after being in the getting surfactant and getting resuscitated at birth. CPR was performed for 25 minutes. The kid was given multiple different meds. And then they did an echo after the kid got ROSC back, and they showed a which is for a kid this age, a pretty good sized pericardial effusion. So they realized, oh, we got to drain this effusion. The kid needs this, or this kid's not going to make it and could code. So they asked around the valley, and nobody could perform this pericardial centesis or felt comfortable doing this window because the heart's about the size of a walnut at this point, right? So imagine now trying to get 7 mLs of fluid off of that and not hit the heart. So they said, well, we're going to have to send this kid to PCMC in Salt Lake to get this done. So the match is called and they get ready to take this call. Next slide. And then when they get there, they're like, okay, here's the plan. We're going to give you this kit. If this kid arrests, we want you to then try to get this blood out of the heart. And luckily, but no physician in the valley was willing to perform the procedure on this small infant. So what would you do in this situation if you were the team and the physician's handing you a kit to say, if something happens, give it your best shot? What would you do? Spell your last name, right? Right. What would you do? Okay. Okay, so Leslie said, call MAOC and say, we just got this bag. What should we do with it? Okay, that's one option. What's another option? Not do it. That's what Brandy said. Okay. It's not in your, right? It's not in your, okay. So next slide. So Match refused to perform the procedure in the event of cardiac arrest. Basically, the answer was sometimes people die. And that doesn't mean that we go outside our scope, which is exactly the correct answer, right? Because what would have happened if the kid would have arrested and then they would have stuck the needle in there and he didn't live? Can you win that argument? No, because you're doing a procedure you're not qualified to do. If the kid dies because they knew they had to get to primary, but the kid didn't make it, that's just a part of the natural course of this poor kid that was born to this mother and was premature in the first place, right? So although we have a desire to do what's best for our patients, sometimes that best is remember to first do no harm. And sometimes that no harm includes not doing something to someone you don't know how to do in spite of the fact they may die. Okay, there's protocols that we have for a reason. So before I think the big thing is, just as a reminder, this is a stark reminder, we have protocols for a reason and you shouldn't deviate from them without MAOC discussion. And if you do or you realize you've deviated, you should contact MAOC immediately to discuss it because you're not protected from an adverse outcome outside of your physician protocols without consultation. That's the bottom line. You're now practicing on your own and you don't have a license to do that. Thought that was just a good case to review for that reason. So we took a lot of time today on clinical cases, but I think there's some good education. So thank you everyone for your participation.
Thank you. Yeah, I think those cases were very important to spend time on. All right. I know that we are running into time. However, I think this particular topic here of safety that we're going to have Blaine and Victor come up and talk about is very timely and important. So if we do run into time, we will end on time and then we'll send out an email or communicate out the rest of the updates. So Blaine, you'll be first. Yeah, yours about culture of safety.
Yes. Who saw that email? I know you saw it. I know you saw it. Thoughts? Feedback? Thank you. Thank you. Yes. I wanted to get the message across that it's something that we're going to take very seriously, have taken seriously, but we have pockets of opportunity. We do. And what I want to do is just say is we're in this together. What is a culture of safety and who owns it? That's a question. Who owns the culture of safety? Is it me? Is it Shandy? Is it everybody at the bases, right? It's how you show up with each other. It's how you talk to each other. It's how you're curious. you interact well. In EMS, we are quick to judge. We rush to judgment. That's our job description. This is what it is. This is what I'm going to do about it. I just encourage everybody to stay curiously just a little longer and understand that everybody owns the culture of safety. And you see variations across different bases. You see some variation across different teams. But that culture of safety, we just need to make sure that we reflect as an individual and as a team, how do we do this here and how do we make sure we're all safe here? The culture of safety scores indicate that we have some work to do. 47% of us participated in that. That means over half didn't. That's a metric. So if it's survey fatigue or if it's didn't see it in the email, I don't check my email, I don't read my email, I opt out of doing those tasks, maybe reflect on that as well. The 47% that did participate showed some areas where we will need to focus. All teams are going to focus on the 3 areas of senior leadership values, diverse perspectives, even if different. So the leadership team is going to be curious longer, listen to understand. And if somebody's bringing in an issue, instead of saying, well, yeah, that's how we've always done it, or, well, you just need to go learn this or that, we'll be working on that. Safety risks are quickly addressed. So when they get entered in a ninth brain or speak up, we'll speed up the process in which they are addressed, or at least acknowledged, like, hey, we see this, we're working on it. It is going to get handled quickly. Safety training is provided is adequate. Yeah, that's a true statement. We probably haven't done a great job of providing enough safety training. St. Luke's has a program called Safety Together, right? Everybody gets to do that on Curio from time to time. We're going to do some more focused training. One of the things that's going to help is, a few months ago, we put in a FTE request for a safety officer, got that approved. We'll be selecting that person to help with some of those activities in early December. We'll also be rounding with a safety focus. It's called 4C rounding. Be some specific questions. We'll be following up with the supervisors and other leaders and medical directors and everybody that's doing that rounding. We'll be able to collect that information. And then self-reflection. We all think we're great at safety, but not others. That's one thing that was in that culture of safety. It was 98% said, "Oh, I'm really great at safety. Me, I'm great." But those guys or those guys, so the people to the left and right, they suck at safety, but I'm good. So I just think we need to maybe understand why that might be. If there's a bias associated with that, if there's some sort of, I don't know, something there. So, and that's all I have. Any questions? Comments? Rude remarks?
All right. So as we kind of come into winter, I wanted to kind of clarify some things and also educate you guys about our weather declination process. So first thing to understand about this is really understand the role and responsibility of the transfer center as well as the comm center. So their mission is to facilitate safe transport of the patient. And how they do that is, they go through a selection of the most appropriate team. They look at the modes, the acuity level of the patient, and then also crew configuration of what this patient needs. And because we're such a large service, we got, we can offer so many different types of modes, so many different crew configurations, up to hybrid teams where we'll place somebody from match along with CCT. So there's definitely different ways to skin this cat. So one thing that's really important to this whole thing is the due diligence process when we do a weather declination. So why? If you look at some cases where the time sensitivity is an issue or this patient is due for a life-saving procedure and somehow we cannot get that patient the fastest mode, we need to provide documentation as to why we couldn't do that. So one way, because we are tasked with safe transport, so an example would be TSE, STEMI in Wood River. we cannot fly. So we have to document the turndowns for Boise, for Twin, for Burley, etc., because we're going to send them probably the slowest mode of transport for something that's so time sensitive. And we have to document in our process, we did our best. We looked at all these things, we try to give options and come up with a solution. And so when you do that, um, sometimes you'll get kind of a hint that, others have turned it down first. So we'll say like, hey, ASL 1 out of Boise, just be advised, Twins turned it down. Be advised, Burley's turned it down. We basically know what you guys are going to answer. You guys are going to probably say you're going to turn it down too. We cannot call it for you guys in Comm Center. That's a pilot in command situation, but we expect it so we can document it. And when we document it, we don't take it personal. We just move on from plan A, B, C, D, etc. Important in that is when we talk about the pilot in command, there's no pressure to go and there's no pressure to not go. What you guys can do is definitely ask for clarifying questions because every pilot has their own tolerance for risk. So a lot of our pilots are coming from Alaska, flying backcountry, or the utilities flying power lines and stuff. Their level of tolerance is maybe higher than what we're comfortable with. You guys turn it down if you guys, whatever, just spidey sense or whatever, feel like this call, even though the pilot says it's good to go, your safety tingly spidey sense says no, then just make that call on your own. Like I said, we don't take it personally. If you're not going to hear us like, you have to go. This patient's going to be, you're going to die if you don't. Us in AOC or being admin on call, we just need that quick answer of, are you guys accepting the call or not? If you guys don't accept the call, great. We just roll it through. The other question is it within your scope of practice? So with that one, the things that we've kind of looked at through case reviews and such is we sometimes look at their what treatment was provided to them on scene, and then we associate that with, oh, this is the ALS or this is BLS. But the trap we fall into is a lot of these calls are scene calls with walls. That patient just rolled through the door. This person is going to require chest tube, is going to require, invasive monitoring, etc. So we try to lean towards a little heavier sometimes, if that makes sense. And then finally, I wanted to kind of touch on the topic of winter ops. So here at St. Luke's, we definitely have a lot more options too, not only in the mode of transport, but we're also talking about like what other operational options we have. So some of them being a shelter in place, which we found out through CAMES, we're probably one of the only programs in the nation that does that. Is we tie in with VCC, and when we have a weather turn down, that we activate and utilize physicians within the system to kind of give order sets and then have that monitoring take place video wise. The other part is looking at things through an asset utilization context. So a lot of times when we talk about utilization, we're looking at it from a clinical utilization standpoint. So some people will say like, well, are you going to take a CCT team or a match team out of such and such? If it's most appropriate to fly this patient because the roads are crappy, there's winter conditions going on, sometimes we're doing what's best for the patient. And sometimes, so you have to kind of remember that too. And also, when you guys do accept a call, if you guys are coming out of Meridian Helipad and you guys roll out onto the street, you guys haven't even passed Los Betos and it looks crappy, turn it around and just decline it. You know, it's the same thing we do on rotor. We'll pop up, take a look. It doesn't look great, plop it back down. So same kind of expectations. You guys are always, we understand that initial accepting of that flight or call doesn't necessarily mean that you have to keep trucking along. If it's not safe, turn around. Just turn around. Okay. Any questions? I know there's a lot of pings.
Ian, go ahead.
Yeah, kind of just a, and Ryan kind of piggybacked on it and mentioned it in his comment that he put in there with the shopping within our own program, depending on if it, if it's whether from the sending or whatever, looking at that. But my question is, when we get toned out, it just happened last week here at ASL One. Life Flight Network had declined a flight to cancel, and we got paged for it. And it, looking back at the phone afterwards, it came through that they had declined it. But when we get the initial tones over the radio, they don't tell the pilot that it's already been declined by another agency or the crew. And we don't always look at those phones right away on the rotor side. So is there a way to change that process where that's coming across the radio tones dispatch as well?
That's a great point, Ian. And I kind of want to segregate, was that a mistake on one person and not like, putting the blame on the entire comm center? So that's one thing that we'll probably look into. If you kind of give me the details or write a QA about, I can look into that one.
Awesome. Thanks.
Lucy.
This could be self-explanatory, but with shelter in place, I'm thinking of ASL and 4 in particular. So say we get called out for a patient and then end up being like, okay, weather's not good, we need a shelter in place. Is that our patient? Are we working under our protocols? It's the hospitals, it's a dynamic process. Are we there as a resource? What does that look like?
So I'm gonna assume that this is kind of an ICU level patient. If it's an ICU level patient that got accepted, say downtown ICU, whether that's MICU or SICU, they would hook in with the intensivist over virtually. So they would give the order sets. And because we are not in the assumption of taking care of a patient load in the hospital, that's not our job. We're there as taskers. We can assist if there's like a rapid response. We can kind of help out with it. But we are not taking a patient load with beds and everything. We don't have Epic access. We don't have, we're not going to be pulling stuff out of Pixis and doing cares and all that other stuff. We can help out, but that patient is going to still belong to the facility. And then the only thing that's going to change is the intensivist is going to be going through the video system and kind of giving order sets to the facility. Yep. Any other questions? Excellent questions.
So I'm gonna scroll up here a little bit and read Ryan's question so we can directly address it. So he said here, what point does it become kind of shopping within our own agency if there's unavoidable routes due to weather? Why are we still checking and kind of going through that piece?
Kind of along the lines of like just above where we're just going through our due diligence process. Sometimes we have to document that we tried our best. So sometimes if let's say we have a person that needs to get a sleeve on a AAA or something like that, this patient's going to be a high level of mortality, but we're sending them a ground unit knowing that they're going to be on snowy roads for an hour or two. But we have a helicopter, if weather was clear, could get them there in 12 minutes. So there's that part about like having the justification and documentation to kind of support that. So it's just that we have to show that we've done our best. And sometimes the option is there's nothing we can do about it.
Another question here from Brad. With all the new people without the depth of experience, how do we teach them the difference in risk tolerance? And he says, I hope they'd ask questions to clarify, but without the depth of experience, they might not have that kind of spidey sense. I'll give my 2 cents on this since I've been working with the group. They do have a fair amount of experience coming in. I think this is a pretty unique group that brings a lot of experience. It might not be Air St. Luke's, but it's a lot coming in. So I think that will be helpful. And then as we train them, building on that culture and trying to kind of pair experience with non-experience to continue to build on that. But I'll let Vic touch on it as well.
Yeah, absolutely. I think part of it is having that line of communications with your team and always be curious about it, always ask clarifying questions. And if something just you're still not comfortable, it's always okay to just say, yeah, this is not I don't feel great about it. And it's okay to do that. So one example is snowy roads. Me, I try to avoid the white stuff as much as I can. So my winter driving skills is probably not going to be the same as somebody that grew up in Riggins or something. So it's just that kind of level of comfort and also skill set. But definitely, if my answers don't align with your level of safety, our biggest mission is everybody comes home. So that's the biggest thing. So if it does not make sense to you from a safety standpoint, just decline.
Okay, one more comment and then we are at time, so we do need to wrap up.
I was just going to say, I think this is to Ryan's point, considering if we know that conditions at sending are bad and we're considering rotor, and this is just something I did at previous programs within our program. If we knew that we got declined at sending or at scene, we didn't keep asking. And I feel like that's something that within our program, we can safely say that, hey, we probably shouldn't. We'll move on to the next mode to see if it's safe to go by fixed wing and then ground in, because there's different minimums and stuff. Or if we need to then, that gets declined, then go by ground. But it's bad enough with the teeth pulling that we have to go through with other organizations to figure out why they declined, that I don't feel like we need to be saying that, okay, ASL2 declined for whether at sending, whether at scene, and then ask ASL1 or ASL4. Now, if it's en route and they're coming at a different route, that's acceptable. But I don't think we need to shop after declining at scene or at sending within our own organization, because we had to fight with LFN to get information, or I forget that other Oregon organization, like they had 3 aircraft turn it down, the other week, and we didn't even get told from dispatch that someone had declined it, and they had to, beg through the hospital to find out who they had shopped it to, and then call them directly. It was a nightmare. And it's like, if we can simplify this a little bit and remove some of the subjectivity and go with the most objective answer, I feel like that's the most safe thing that we can do, at least with what we have in house. But that's just my thoughts.
All these caveats, right? Whether it's sending, weather, and route, right? Who makes that call? Is it the pilots or is it the comm center, right? So it's the pilot in charge duty to like look at it, say, I'm not going, right? Now, if they should be armed with the information, other programs or our internal things have turned this down for weather, and then go, yeah, I concur. There's a big red thing right over sending. I'm not going. But we can document it instead of having the comm center going, okay, is this weather en route or weather on scene or sending, and documenting. We just need to capture, ASL2 pilot turned it down, ASL1 pilot turned it down, ASL4 pilot turned it down, looked at fixed wing, turned it down, going to ground. Like just that sequence, something like that.
And also, if the weather, I'm sorry, if the pilot somehow indicated that, hey, maybe check back with me in whatever time, that's when we'll kind of set a clock too. So if they say like, oh, we're going to get another weather reporting in 2 hours or so. Okay, in 2 hours, we set a timer. We're going to call them back. and then we'll check again. So there may be some duplicity in that where like sometimes it sounds like, okay, well, we keep asking or pressuring. Kind of depends on what the pilot states to us too. Because depending on which pilots, they're really good about like either saying, looking and forecasting and say, hey, give me another hour. I think it's going to pass through. So then, it's not convenient. Sometimes it wakes us up, right? But like, oh, we'll get another buzz in an hour and says like, oh, can you recheck that weather? Does it look any different? So there's things like that, but also it just kind of, I think we get a partial message when we go through comms. Sometimes it depends on what that first initial pilot is told comms. And if they're saying like, hey, there's just one cell that's just sitting right over us or something like that, which is common in like certain parts of our geography. It just sits right over an airport or right over a helipad or something. So in those cases, then it is appropriate. So it just kind of depends. I know it's really tough to apply a standard for everything we do because we run into so much gray area a lot of times. But it definitely falls back to the whole thing of like if you guys are not comfortable and it's not falling within your risk tolerance, turn it down.
All right. With that, we're going to conclude the clinical meeting for today. There were some educational and quality updates, which we will send out. And I think Cody especially wanted to call out that you only have about, 6 weeks left for clinicals. If you haven't started them, get on them. It has gotten pretty packed. It's December, especially OR. And then we've got new hires that need to go through too. So get your clinicals in. Cool. Thanks, everybody. Oh, and EMS charts live, or now went live. Now.